Good morning, everyone. I've been asked to talk about diathermy and how it works. Quick outline of the talk this morning. I'm going to speak about what diathermy is, its uses, the history of diathermy, its mechanism, whether bipolar or monopolar diathermy is the diathermy for you, risks of using diathermy, a quick summary, and then some pearls of wisdom. So in general terms, it's electrically induced heat used as a physical therapy. That's its correct definition. We use it as a slightly different term. It's better referred to as electrosurgery or electrocoagulation, but in effect, we surgeons refer to it as the use of high frequency alternating electrical current to cut or cauterize tissue. And there are various uses, forms, and settings around diathermy. Well, it's a fairly universal feature across all surgical specialties. I was hard pushed to think of a specialty which doesn't use diathermy for at least some purposes. Mainly, certainly in orthopedics at least, cutting. So in surgical approaches, for instance, laparotomy and hemiarthroplasties, use diathermy to rapidly cut through tissue and partially cauterize it at the same time. You also use it to dissect structures free from vascular surroundings so that any bleeding vessels are burned at the same time as you cut. It's also used for coagulation, as I've mentioned, and that's for more formal cauterization of bleeding vessels. You can often find that as you use the cut setting and go down through tissues, you still do have some bleeding points which need coagulation with a different diathermy setting. It was first developed at Harvard University by William Bovey, whose name still adorns a company which makes diathermy machines. It revolutionized surgery in general, but more topically at the time, it made much more complicated neurosurgery possible because bleeding was the limiting factor in many brain operations. And William Bovey, as a fun fact, though not so for him, actually sold the rights to his invention for $1 and unfortunately died in penury at the end of his life. It was first used in 1926 by Harvey Cushing, who is referred to as the father of modern neurosurgery, to remove a mass from a patient's head. Cushing himself was the first exclusive neurosurgeon, and his name is still attached to Cushing's disease. And after its initial invention in 1926, it went through the usual rapid development and progression to the point where in the 1940s there were low-powered handheld devices for taking off lesions of the skin, one of which is called the Hyfrocator, with a suitably retro-looking piece of equipment here, which actually came from the 1980s. You can tell from its font and its beigeness. What mechanism do we use? So this is a finger switch on the right, which will come up later. Effectively, we apply current to tissue using a finger switch or another device, and that current is an alternating current. The oscillation of ionized molecules within cells increases the intracellular temperature. So you're effectively lining up these ionized molecules in one direction and then very rapidly flipping it to the opposite direction, and this oscillation increases temperature, as you might expect. Increased temperature leads to a variety of effects, and we can take advantage of different temperature brackets to cause different consequences. So at about 60 degrees Celsius, you experience cellular death. Effectively, the cell denatures and can rupture, but it's a more gradual process. And this low temperature diathermy is used for things like skin lesions and very superficial things which don't require much tissue destruction. Between 60 and 99 degrees Celsius, you experience tissue desiccation and protein coagulation. This is ideal for coagulating blood vessels or dissecting out structures where you want to ensure that there's no bleeding present. And this is a sort of slightly less rapid coagulation and cutting process. And finally, at above 100 degrees C, the cells experience rapid vaporization, and it's this kind of region that your cut setting operates in. So coag setting, so the blue button you can see on the finger switch, results in lower temperatures, and that's aiming to coagulate bleeding vessels without absolutely destroying the tissue around them. And cut setting, so the yellow button on your finger switch there, results in higher temperatures, vaporizing tissues and making cutting much more efficient and straightforward, but with more tissue destruction as a result. And there is some overlap between the two settings in terms of temperature brackets. Mechanism 2. So to start off with, all diathermy systems are bipolar, but the position of those electrodes varies, and so we've come to the point where we, admittedly incorrectly, refer to there as being two main diathermy modalities, bipolar and monopolar. So monopolar diathermy, in inverted commas, the electrodes are distant from each other. Your finger switch, so the actual piece of equipment that you're holding, has one electrode, the active electrode, and that's got a small tip, and then there's a dispersive electrode placed elsewhere on the patient, and effectively the current flows through the small tip, which concentrates that current into a very small area, causing the increase in temperature, and then that current is dispersed over a much larger area with a large sticky pad electrode, usually on the patient's back, to prevent any burns underneath that electrode. Bipolar diathermy, by contrast, both of the electrodes are close to each other, and they're usually in a pair of forceps, with one electrode on one side and the other electrode on the other side of the forceps. And what that means is it only allows current to pass between the tips, which is very useful for controlling exactly where you want your tissue damage to happen, but less useful if you want to do more broad brush and larger cuts. So various waveforms and voltages are used to generate differing effects, and I won't go into too much detail, mainly because my physics is somewhat rusty, and also I could be waffling on about different wave patterns for a little while. So basically though, higher voltage causes increased temperature, as you might expect, and both cut and coagulation settings use a sine wave pulsed at differing frequencies and voltages. So you have a standard sine wave, and then that sine wave is switched on and off in a pulsatile fashion, and the amplitude of the sine wave is the voltage, and the main figure you're looking at is the voltage difference between one peak and the corresponding trough, and that governs how much energy is being passed into your tissues. The sine waves are pulsed to prevent cumulative tissue heating. You can imagine if you just carried on absolutely going to town with your cutting, the tissues would gradually heat up more and more and more, and cause a much larger area around the tip of your diathermy finger switch to be damaged. And so those sine waves are pulsed to try and restrict to the very tip where the heat damage is occurring. And along with high voltage, cut setting is pulsed at higher frequencies to generate higher temperatures. Bipolar or monopolar diathermy. Monopolar is probably the most commonly used in most orthopedic surgery, and I'll go a step further and say it's probably the most commonly used in most different specialties within surgery. It's efficient cutting, it's efficient coagulation, and you've got a simple finger switch, which, working a bit like a pen, is quite a familiar thing to use. It works well in wet tissue, it can work underwater or under blood, more relevantly to surgery, but on the flip side, it can interfere with pacemakers and ICDs, which patients do not tend to appreciate. Also, you can damage tissue inadvertently along the length of the finger switch blade, because whilst you're thinking about the tip, actually there's a good 2 or 3 centimeters of exposed metal which can conduct the current and damage skin edges and surrounding neurovascular structures. By contrast, bipolar gives you much more precise control over which tissues you're burning, in that anything between the electrodes gets burned and anything around the outside probably doesn't. The current only flows between the electrodes, but it can be a little bit more finicky to handle, mainly because if you touch the electrodes together, nothing gets burnt at all, so you have to kind of hover them apart, and it's hard to cut things or coagulate things in large areas because you've only got very, very tiny tips. You'd be there all day doing little tiny burns to try and coagulate a massive area. And the other thing to say is it only works on structures that can be grasped between the tips. So, for instance, one of the uses for cutting monopolar is laparotomy incisions, and obviously pinching little bits of tissue with a pair of forceps isn't the best way of making a big cut in someone's abdomen. Does diathermy hold both to us and to the patient? Funnily enough, burning, whilst the intended consequence is burning bits of the patient, you have to make sure the bits you're burning are the right bits and not everything else. So as we mentioned before, the dispersive electrode is an electrode which allows the current to disperse without causing any thermal injury to the patient. Obviously, if you reduce the area of contact or reduce the quality of contact, you can get burns underneath the dispersive electrode, or in terms of partial contact in a small area of that dispersive electrode. Other worries are metalwork within the patient, for instance, arthroplasty or plates. The way to prevent this is to place the dispersive electrode on the opposite side to the metalwork and between the surgical site and the metalwork itself. If you leave it in the standard position when there's metalwork in the way, effectively the current takes that metalwork as a preferential path to ground, sometimes via the table, and causes burns at its exit point. And finally, contact with inflammable materials, as you might expect, for something which burns, tends to end poorly for all concerned. And most famously and most notoriously, that's contact with pooled alcohol solutions, for instance, the alcoholic chlorhex, which we use to prepare the surgical site. And there have been a number of cases where that's caught fire and given the patient really quite severe burns. And finally, smoke toxicity, a little bit hard to quantify, not too much evidence. But actually, if you think about it logically, I suppose, as a surgeon, if you're there breathing in vaporized patient smoke, there probably aren't too many benefits to that. And actually, there probably are some risks to inhaling smoke constantly while you're operating. So for any SHOs or assistants, I would advise you to use suction judiciously to try and remove the worst of the smoke before it gets to your lungs. Diathermy is the application of an alternating high-energy current to tissue for a variety of surgical purposes. It's been revolutionised by its invention. Diathermy relies on the oscillation of ions within cells to generate a change in temperature. And bipolar and monopolar diathermy are used for different purposes because they have their own characteristics. And finally, diathermy is not risk-free. Surgery today would be unrecognisable without diathermy. There's no getting around it. Monopolar and bipolar are both modalities with advantages and disadvantages, as I mentioned, and you have to match your modality to your intended use. And finally, my final pearl of wisdom is don't set fire to your patient. Any questions at all?